Next testifier is Dr. David Casseret, Associate Professor of Medicine, University of Pennsylvania School of Medicine, Director of Hospice and Palliative Care, University of Pennsylvania Health System. Welcome, Doctor. You may begin.
Thanks very much. It's an honor to be here. And I thought rather than reading my testimony, I would begin by telling you a story about how I came to be sitting in this seat. I'm, as you can see, a professor of medicine at the University of Pennsylvania, a researcher and a skeptic. And I confess, I've always thought of the idea of medical marijuana as being a bit of a joke, frankly, as a way for people to get access to a drug that causes euphoria legally. And it was partly because of that skepticism that I decided about a year ago to start researching a book that will be published in July by Penguin Random House for the popular press about the science of medical marijuana. And in the process of researching that book and talking to well over 100 researchers, physicians, patients, families, I've come up with a couple of surprises, which I wanted to share with the committee. One is that I've been impressed, actually, that medical marijuana has more evidence to support it than I ever imagined. You've heard testimony so far this morning that there's a lack of data, no good randomized controlled trials, it's all anecdotal. That's actually not true. I've actually been amazed by how many randomized controlled trials there are, how much funding there has been. One of the previous questions you heard was what state has done it well. California actually has invested a fair amount of money in research, including creating a center for research in San Diego. And that research has produced not overwhelming data, but I would say there's good enough to use randomized controlled trial data that marijuana's ingredients are effective in the management of nausea, at least as effective as the drugs we have out there, probably for insomnia, also for neuropathic pain, so pain due to nerve damage. And that's important because as a palliative care physician, I can tell you, neuropathic pain is very, very difficult to treat. It doesn't respond well to opioids like morphine, doesn't respond well to nonsteroidals or Tylenol. It could be very, very distressing. Not dull, achy pain, but pain that's sharp and lancinating and really disruptive. And there are good randomized controlled trial studies done by people like Don Abrams at UCSF and Barth Wilsey at UC Davis that have shown pretty convincingly that it does have effects. That's both THC and CBD. Some of the other benefits I think are more speculative: PTSD, anxiety, depression. I think those, at least to my read of the data, fall squarely in the anecdotal category. But I would say fairly confidently that we do have good randomized controlled trial data out there, and it's not just anecdotal. I promised you two surprises, and the second surprise to me is about the risks of medical marijuana, which is not really what I had expected. Some risks which I thought were real, almost obvious. For instance, the risk of smoking and lung disease seems so obvious as to not be worth studying. Although if you really look at the data, several large case-controlled studies have failed to find any impact of smoking marijuana on long-term lung disease, development of COPD or emphysema, or cancer of the respiratory or ENT tracts. And one researcher I spoke with, Donald Tashkin at UCLA, said he was frankly surprised by those results. The reasons are complex. It probably has to do with a combination of the anti-inflammatory properties of CBD as well as just dose effect. In order to see significant lung effects of smoking tobacco, you need to smoke, right, 1 or 2 packs a day for 10 or 20 years. That's 20 or 40 cigarettes over 10 or 20 years. Imagine if you smoked 20 or 40 joints a day for 10 or 20 years, your lungs would be the least of your problems. And so it's maybe not surprising that we haven't seen those effects. Other effects have been surprising to me, though, and that is the risk of addiction. You know, honestly, I thought that marijuana, if it were addictive, would be addictive in sort of a humorous way, but it's not. I mean, I've become convinced that the risk of addictions, as you've heard, are serious. That's not to say that medical marijuana should be outlawed. There are other substances like morphine that are legal drugs, and other substances like tobacco or alcohol that are also addictive, just to be clear. But I have become convinced that there is a real addiction, there is a real withdrawal syndrome that's recognized in the DSM-5. So those in broad categories are two surprises. There's much more evidence than I ever would have imagined, and there are some risks that are some more significant than I would have imagined, and some less so. And so my plea to this august body would be to think very carefully about those data and to treat with skepticism the testimony that you've heard that, oh, it's just anecdotal, or conversely, some promises that either CBD or THC or both are the miracle drug. It's probably not either one of those. And so we need to be both skeptical and then open-minded. Other things I've learned along the way, which I'll share with you very briefly, are, first of all, I would hope that the Commonwealth of Pennsylvania, if we consider this seriously, puts in more safeguards than other states have, both in terms of who can get access and what sort of counseling patients get. It's all too easy for patients in many other states to get access to drugs without good counseling. And last but not least, testing. I think the most important thing that some states like Colorado have done is to mandate testing, so consumers know, patients know exactly what's in everything they're getting, both in terms of what should be there, meaning CBD and THC concentrations, but also what shouldn't be there, like pesticides and molds and fungus and bacterial counts. So those sorts of things I would hope would be an important part of whatever we develop going forward. So thanks.